Hello guys, hello family, hello friends. This is Dr. T speaking. I hope you guys are enjoying I hope you guys are good. I hope you guys are good. Hope you guys are doing well. Um and I also hope that you guys are enjoying the channel, the content, and I hope that the content in the channel is giving you something different, something fresh. And most importantly, I hope that you are growing as an intern, as a student, and growing in knowledge, growing in wisdom, growing in you managing your patients. While I'm still at this, I want to thank you guys from the bottom of my heart. I thank you so much for subscribing. You guys have been amazing. The channel is only about 3 days, and already we are having about 113 or 14 subscribers. That's amazing. Thank you so much, guys. Thank you so much. And I would encourage you to keep sharing the channel, keep telling your friends about it. This is like medical concepts really made simple and easy to digest. And yeah, like I always say, ever since I was a student, my approach has been sort of like different. I believe in looking at a symptom, and as I look at a symptom to try and find a diagnosis. You know, majority of us, we know a lot, we study a lot, medical school, we study a lot, and we know a lot of things. But when a patient is put in front of us, it becomes very difficult to move forward. It becomes very, very difficult to diagnose. Even history taking becomes a challenge. So I want to break that. My approach is to look at a symptom, and try and end with the diagnosis. You know, sometimes you can know heart failure in and out. As you study, you know heart failure, you can even sing heart failure. But now a patient is put in front of you. When a patient comes, they won't say, I've got heart failure. Heart failure will not be written in their foreheads that they've got heart failure. They will come with a symptom. So we need to develop a way of a way that will make us to be able to look at a symptom that a patient presents with and be able to find a diagnosis. So thank you so much, guys. Thank you so much. Thank you from the bottom of my heart. Thank you for being a part of this. I don't know where this thing is gonna end. I don't know what's gonna happen. For now, I'm just enjoying sharing this kind of information to you. So yeah, let's get into it. So today, let's do upper GI bleeding, a surgical emergency. So upper GI bleeding, once again, it's gonna be a broad overview so that you know where things fit. So a patient comes, they are saying, let's make a scenario. We are sitting, it's lunchtime, sitting and chatting as doctors, and then a nurse comes in and saying, doc, we have an upper GI, we have a vomiting patient. So we have a vomiting patient that is vomiting blood. So that's hematemesis. So the nurse is saying, doc, the patient is having hematemesis or is vomiting blood. And one thing that I'm gonna ask the sister is, because I'm on lunch, so what I wanna know is this patient, sister, stable or unstable? And then the nurse says to me, no, this patient is not stable. I won't ask anything further. I'll go and see the patient because the patient is unstable. So, stable or unstable. Whether the patient is stable or unstable will make me to decide whether I go and see this patient now or I can finish whatever that I'm doing. So she says the patient is unstable. So when she says the patient is unstable, I expect that the patient will have hypotension. Or a shocked patient because they are losing blood. I expect a patient that has got a tachycardia. Meaning a heart rate that is greater than 100. Actually, a tachycardia that would worry you, that should really worry you, is a tachycardia of more than 115. That's a tachycardia that should worry you as a doctor. And then maybe this patient has got is dyspneic as well. The RR is greater than 20. This patient has got low sets less than 90. This patient has got an altered mental status. Altered mental status. This is an unstable patient. So this patient needs resus. At this point, like I always say, at this point, whether the patient is the cause of the hematemesis is not important at this point. What you want is to resus that patient, because the cause of the hematemesis is not really going to change your management in terms of your resuscitation. The management, your initial management, which is resuscitation at this point, will not be influenced by the cause of the hematemesis, but later on it will. So it will be important to take the history, but at this point you want to save a life. This issue of bleeding patients, it doesn't change whether it's PV bleeding like I showed yesterday, whether it's PV bleeding, whether it's a stab, whether it's lower GI bleeding or upper GI bleeding. If it's bleeding, this is what you want to know. So you will resus this patient. You will have to resus this patient up until you get to a point whereby this patient is stable. So you don't have to have all of these things to declare a patient unstable. A tachy and a hypotension already, that's an unstable patient because the vitals are not stable. You don't need to get all of those. The time you have all of those, that's like a very sick patient. So how do you manage this situation? You call for help. You call for help to large bore IV lines, oxygen by mask, and then as you do that, you take bloods. The bloods that you take for a bleeding patient, they never really change. Platelets, INR, HB, cross match. Like I said, when you give a patient normal saline or Ringer's lactate, as you give them fluids, so at this point you are just doing a fluid resus, and you keep checking your patient. You keep checking your patient, checking their vital signs. That are you able to bring those vital signs to life? Are you able to bring those vital signs back to normal? And also, for a patient that has got an altered mental status, you would want to check the blood sugar there. You would want to check the blood sugar there. And one of the things that you also do, you have to insert a catheter on this patient. When you're gonna do a fluid resus, you want to insert a catheter. The catheter will tell you about because you want to monitor the output of the patient. Because if you have a patient that you are giving a lot of fluids, but you are not monitoring output, they might easily run into pulmonary edema, especially if they've got a renal impairment that you knew nothing about, or a renal failure that you knew nothing about. So you want to do those things. You want to insert the catheter and monitor the output. So you resus this patient, and remember, resus can be fluid resus and blood product resus. Like I said yesterday, that when you do a fluid resus, by the time you get to a third and a fourth and a fifth liter, you should have given that patient blood. Let's say 4 liters. Even the third one, you should give it with a bit of reluctancy. So, because the fluid remember, the patient lost blood. They didn't lose fluids, they lost blood. So the right way of correcting that is to give blood, but we cannot be giving blood to anyone. If a patient can receive about 3 liters of normal saline or Ringer's lactate, and then they become better on that, it's fine. The body will replace the red cells that they might have lost. But now, if you're gonna give 5 liters of water, remember, you will be diluting the HB, you will be coagulation factors. They work well on a certain body temperature. Fluids, especially if these fluids are not even warmed, are cold fluids. So you might run a risk of causing coagulation problems by your cold fluids that you are just giving like that. So this is like a big topic on its own. And when you've got a patient that has got an altered mental status, it means that their airway can be compromised at any given point. So you might want to consider intubating these patients. And also, if you have got an altered mental status, you might you run a risk of aspirating. So you want to protect the airway. And so this is a sick patient. This is a sick patient. A patient who's got hypotension, they're in shock, tachycardia. Those ones with fluids, you might get them out of their situation without even taking them to ICU and stuff. But by the minute your shock is not responding on fluids and you need inotropes, then that's an ICU patient. You should get ICU tutors involved. Let's say now your patient is stable. What do you do? So the patient now is stable. So what you want to do here, you want to do you will take your history now. Take your history. And as you take your history, in your mind, you want to decide. Is this patient bleeding from varices or is having non-variceal upper GI bleed? So in upper GI bleeding can either be variceal or non-variceal. So as you take your history, someone who is taking a history from a patient and they know exactly, they have differentials, their history is different because they have differentials in their mind that they want to roll out or roll in using history. So their history is like specific. They're asking specific things and they're expecting the patient to tell them specific things. So here So this is how you classify upper GI bleeding. Is it variceal or is it non-variceal? So a patient who's having if you can look at this classification, whether the patient has got variceal upper GI or non-variceal upper GI was not going to change how I was going to manage the patient if this patient was unstable. This is what I want to sort of like drill into your mind, guys. So, but now, because the patient is stable, so I want to know, because I want to give a specific management. So what do you do? So a patient who has got, let's start with variceal. So it's someone who is okay. Before I get there, let me just tell you the difference between, because now we're dealing here about upper GI and lower GI. So the difference between upper GI and lower GI. So the stomach is like this. So at this point in the duodenum, there is a ligament that attaches to the vertebral column. That ligament is called the ligament of Threads. Bleeding that happens above this ligament is upper GI bleeding. Bleeding that happens above this ligament is called upper GI. But bleeding that occurs below this is called lower GI. That's how we differentiate. And these patients, they present with hematemesis and melena. These ones, they normally present with hematochezia. Hematochezia is a bright red blood that can either come frank or it comes with a stool. So that's a hematochezia. So that's what I wanted to just explain to you guys. So now a patient that has got variceal bleed is someone who is having ruptured varices. And now when you ask a history from these patients, what you want to know is the history of alcohol abuse, history of liver disease like cirrhosis, and so the major cause is liver cirrhosis. So you want to know about the history. And this patient, they might come to you. You might not be the first person that they are seeing. They might have been having this upper GI because of these viruses. Because viruses they rupture anytime and they rupture repeatedly. So they will give you that history, and they might have signs of portal hypertension and all of those. So when you examine these patients, the things that you want to look at is the stigmata for liver disease, which is they might have jaundice. So you have taken the history. They might have jaundice. They might have palmar erythema. They might have ascites. They might have hepatomegaly. They might have swelling of the legs. They might have what other stigmata for chronic liver disease? They might have hemorrhoids from portal hypertension. So basically, this is what I also need you guys to go and look up. Clinical features of chronic liver disease. They might have gynecomastia. They might have spider nevi. They might have. So a patient who's got upper GI bleeding, they've got these symptoms, you can be sure that they are having variceal bleed. But if you have a patient upper GI bleeding, but they don't have any of these, that's called a non-variceal bleed, upper GI bleeding. And what are the differentials for that? So what you're gonna ask these patients, these ones you ask them about alcohol, you ask them about chronic liver disease, you have asked them about portal hypertension symptoms and all those things, and you have asked them about the history of alcohol use and all those things, alcohol abuse, all those things. But this one, it's different. Because the differentials are different here. The differentials here is your peptic ulcer disease, which can be gastric, which can be duodenal, and they might be having esophageal ulcers. They might be having esophagitis. They might be having what they call a Mallory-Weiss. So Mallory-Weiss basically someone has been vomiting for a long time, and they start to damage their inner lining of their esophagus. They might be having a gastritis. They might be having duodenitis. Yeah, it's not common for a patient who's got gastritis to have upper GI, but anything is possible. So those are your differentials for a non-variceal. And out of those differentials, the most important one is peptic ulcer disease. And peptic ulcer disease deserves a video on its own. Peptic ulcer disease. So now, and you guys, if I'm forgetting anything, you can also add it as a comment there. I'm so worried that you guys, none of you has commented, but you have been watching the videos. Please feel free to comment. Feel free to ask questions, because when you ask questions, you are challenging me to go and look for information and come back to you and give you the answers. So I'm gonna quickly go back to this again. Upper GI bleeding, patient has got hematemesis. They might even tell you about melanoma stools. Is the patient stable or unstable? If they are unstable, resuscitate them up until they are stable. When they are stable, take history, physical examination, and as you take history, you are trying to find out the cause. You want to ask about stigmata, because upper GI bleeding can be classified into variceal, non-variceal. If it's non-variceal, differentials, peptic ulcers, esophagitis, esophageal rupture, Mallory-Weiss, and like I said, the most common is peptic ulcer disease. Variceal bleeding, patient with jaundice, pulmonary edema, gynecomastia, ascites, hepatomegaly, splenomegaly, spider nevi, hemorrhoids. So now, how do you manage these patients? These patients, the non-variceal patients, the way you manage them is, like I said, if they need resus, you will resus them. If they need resus, you will resus those patients. The drugs that you're going to be using here, because what you want to do, you want to get these patients to be done. You want them to be done in endoscope. That's what you want, so that you can get a diagnosis, so that you can get a diagnosis, get to the bottom of the cause of the bleeding. If it's an ulcer, where is it? And also determine the chances of this ulcer rebleeding, all those things. So basically you want to find a diagnosis. Remember, it can be any of these. So endoscopy is the only thing that can tell you which of these is the patient having. So that's, you want to get them to the endoscope, but you cannot send them to endoscopy if they are not stable. You need to stabilize them. So the drugs that you use there, obviously we've given the fluids and all those things. So you want to give them PPIs, proton pump inhibitors. These drugs are known to cause, they are known for, basically what they do, in the stomach we've got hydrochloric acid. And remember from chemistry that when you've got a lot of proton, like H, and it is a proton, a H plus is a proton. So when you've got a lot of H, that when you've got a lot of H in your protons in a solution or in a medium, then that's acidity. When you reduce those ones, then you have a chance of pushing the whole thing to be alkaline. So these are what I'm talking about, H plus. When you've got a lot of these, your medium will be acidic. So proton pumps, your gastric cells, the more they pump H plus in your stomach, they are increasing acidity. So these proton pumps, they block this from happening, so that the gastric cells do not keep on secreting those protons, in an attempt to try and reduce the acidity of the stomach, because clots, they do not form well when you've got too much acid in the stomach. They don't form well because the fibrin that is needed, remember, fibrinogen, fibrin, all those things, those are proteins. And when you expose a protein to high temperatures, they denature. When you expose a protein in an acidic medium, they also denature because of the extremes of the temperature. So when you do this, you are giving the gastric the inner wall of the stomach, you are giving it a chance to form a clot, because you know that as long as you've got these guys, in the medium, you will delay forming a clot, or you might not form a clot at all, and you will continue to bleed. And you don't want to take an actively bleeding patient to endoscope, because you won't see anything, because you want to see. So if the stomach is full of blood, then you won't see. So that's why endoscopy should be done when the patient is no longer bleeding, and it should be done within 24 hours. So you give them PPIs. The PPIs that are common it's pantoprazole. This is the one that is common. I'm not sure about the dose at this point. It's been a while. I'm not sure if it's 30 milligrams or 80. I think it's 80 milligrams. So you give that 12 hourly. So that's the reason why you give, because you want to stop the bleeding and you don't form a clot when there's too much acid in the stomach. That's why you give that. The next thing that you give erythromycin. Why do we give erythromycin? Erythromycin is an antibiotic, right? But why are we giving it there?